Hi, everybody. This is Karla Hiravi, and it's the top of the hour, so we're going to get started here. We have a lot to cover. Little technical glitch. You can see our Dr. Kendall Smith, but my camera doesn't seem to be working. So anyway, yeah, he's a clown. He's a clown. So, okay, so today you asked for it, winning appeal language. This is, you know, we ask every time on the survey for our webinars, what do you want to hear about? And this comes up so frequently. So we're going to give you a lot of case studies. Let's get going. Tammy, if you could turn the slide. All right. If you see, you have a little control panel there, and you can control it. There are handouts down toward the bottom. You can download the handouts from there. And down at the bottom is where you can submit questions and comments in that question panel. And at the end, we will do our best to get to as many questions as we can. And those that we can't do during the webinar itself, we will do our very best to answer them afterwards. Okay, Tammy? A little bit about AHDAM. AHDAM is the Association for Healthcare Denial and Appeal Management, the nation's only association dedicated to healthcare denial and appeal management. Our mission is to support and promote professionals like you working in the field of healthcare insurance denial and appeal management through education and collaboration. And our vision is to create an even playing field where patients and healthcare providers are successful, persuading medical insurers to make proper payment decisions. Our website is right there if you would like more information about AHDAM. And AHDAM is created through the generous support of PayerWatch. Okay, next slide. So just a little bit about PayerWatch. PayerWatch has several components to it. One is PayerWatch AppealsMasters, where thousands have been trained in denial and appeal management. Strongly believe in a clinical legal approach, which we will talk a little bit about today, and about taking your appeals all the way. That is very important. You want to take your appeals as far as you can. A little bit about PayerWatch Veracity. It is a leader in the denial prevention industry, and it is software that was developed to be in service to providers in protecting revenue. If you would like a little more information about PayerWatch, the website is there. Okay, Tammy? So let's talk about CEs, and contact hours. As has been said at every webinar, free CEUs are offered to AHDAM members only. So to obtain those CEUs, you must be an AHDAM member. You must attend the live webinar for at least 53 minutes, unless you're a physician, in which case you have to attend the entire presentation. You must complete the survey that'll pop up automatically for you at the end of the webinar. CEU certificates are usually emailed to you within a week of the webinar. CEUs are not available for watching the recording. And a disclosure, no individuals in a position to control content for this activity have any relevant financial relationships to declare. Next slide. From the survey, the one that pops up at the end, you'll be prompted to select the desired CEUs, as long as you're a member, as many as are applicable to you. Today, we're offering a Medco, Certified Clinical Documentation Specialist through ACDAS, the National Association of Healthcare Revenue Integrity, NARI, Commission for Case Manager Certification, and we are awaiting approval for the American Nurse Credentialing Center through NEMSD, but we think that we will have that anytime. So you can click on that should you want that. Next slide. All right, CE language for physicians. I'm not going to read all this. I encourage you to read it. It gives you some information about about the joint accreditation statement from the Medco. And next slide, Tammy. All right, the objectives, and these are the objectives for everybody. After attending the program, you should be able to self-report via that survey that you can identify one successful strategy, consider when writing healthcare-related appeals, one common mistake to avoid when writing healthcare-related appeals, and one strategy that is frequently overlooked when writing healthcare-related appeals. So those are some of the things that we are going to cover about that. Next slide. And we're still on a Medco. And if you are a physician, the instructions on how to get your certificate are there. Next slide. Okay, today's program is jointly provided by AHDAM and PayerWatch. The Association for Healthcare Denial and Appeal Management, AHDAM, publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all AHDAM members. AHDAM does not certify the accuracy or authority of these materials. These materials are distributed and presented as research information to be used by AHDAM members in conjunction with other research deemed necessary in the exercise of AHDAM members' independent professional judgment. AHDAM claims no liability in relation to reliance on the content of these materials, and the views expressed in the materials are the views of the materials authors, do not necessarily represent the views of AHDAM. Any references are provided for informational purposes only and do not constitute endorsement of any sources. There are no conflicts of interest to declare for any individual in a position to control the content of this presentation. Next slide. And we did talk about the learning outcomes when we were talking about a Medco. They are the same. Next slide. Here is our presenter. Our guest today is Dr. Kendall Smith. And I apologize, Dr. Smith, I did misspell your name up there with one L instead of two. So I am sorry. So Dr. Smith is a physician at SFHM. He's the Chief Physician Advisor for PayerWatch and AppealsMasters. And AppealsMasters is a leading appeal educator and appeal services firm for hospitals and health systems. He's been deeply involved in denial and appeals management throughout his hospitalist career, has served as a physician leader on hospital revenue cycle management teams while also serving as a physician advisor for clinical resource management. Dr. Smith is also an AHIMA approved trainer and ambassador, and he's an all-around good guy. So next slide. Just a little bit about me. My name is Karla Hiravi. I'm a nurse. I'm presently president of AHDAM, and I'm senior vice president at PayerWatch and AppealsMasters. I'm an RN. I've been an RN for quite a few years, and part of my experience was with clinical document improvement, integrity now, it used to be called improvement, management of a CDI department. Was lucky enough to do a lot of different things, including, but I really became very passionate about writing appeals and trying to support the hospital that I worked in at the time, and then later to help support hospitals around the country. I did continue to participate in and educate clinicians and coders about the medical appeal process. Okay, next slide. All right, we're gonna get started here. Just a little bit of an overview. And we're going to be talking mainly about winning appeal language, but we have to talk about some other things before we get to the actual language. So one of the things that we find are often confused are technical denials versus medical necessity denials. So we are not going to go into long explanations of both, but we are going to give you a little bit of information about the differences. Sometimes we don't always recognize what we need to do in order to overturn a technical denial. We're pretty good with medical necessity lots of the time, but they are different. Coding denials versus clinical validation denials. You have to be precise. You really have to know what kind of denial you are looking at so you can respond appropriately. You have to respond to exactly what is being denied. Okay, next slide, Tammy. All right, this has been my rule number one for a lot of years, and a lot of you have heard this before. So first and foremost, you don't ever, ever, ever believe that the payer's rationale is correct. It might sound lovely, make sense. It might sound like it's perfect.
It's a good life lesson. Just never trust anybody who claims that you owe them money.
Yep, that's exactly right, Kendall. That's a good one. So parents, teach your children that too. So, yeah. So you want to scrutinize every reason that was given to deny. Don't assume that you know the rationale. Look at it every time, because they change their rationale. So be sure you know what is being denied and why. Make sure that you scrutinize, is it correct? Are they correct or are they not correct? Sometimes they are. And you can't really push back if they're correct. But so many times they're not correct. So many times. So you have to recognize it when they are not correct. Next slide, Tammy. All right, we're going to talk a little bit about technical denials. Next slide. Technical denials. Dr. Smith, I think you were going to present this part.
I can jump into this. These are, I think, what you just classify as oopsie denials. These are not related to patient status, inpatient or outpatient. They're not things that are done retrospectively where they're trying to do a clinical validation on a diagnosis. They're not looking at coding or medical necessity. They're not based on coding guidelines. Generally, these are things that happen or don't either happen or don't happen early in the patient's stay, related to registration, prior authorization, network status, or failure to comply with a payer contract. Only after a bill is sent in and scrutinized by the insurer do these things become issues, and then either a recoupment is made after the fact, or you'll get a notice of non-payment with an explanation of benefits returned to the facility. So we'll delve into these here and give you some tips and techniques and tricks that have worked for us to get these overturned. These are fairly unique, and they have to be considered on an individual basis, which is a bit different than strategies for clinical denials. So if you'll move on, we'll jump into this end of the pool.
Tammy, can you move the slide, please? Thank you.
What I work with our staff to do, and whether I'm having a peer-to-peer, which is often an effective way to get these overturned, or whether we're pulling together a letter, you really want to look for extenuating circumstances. What happened here that was beyond our control? And to do that, you need to go back quite often to the registration notes, which are going to be in the patient accounting notes. And that's a different part of the chart. It's generally not part of the medical record. And as a matter of routine, most hospitals do not submit the finance notes, the PANs, to the insurance company. So you may have to ask your accounting department or your revenue cycle for access to these notes as a matter of routine, but they're invaluable. It describes really what the registrars are going through and trying to notify the insurance company that the patient is in the hospital and receiving care. You have to put this in construct of what brought the patient in quite frequently. I've seen technical denials over and over for lack of notification, lack of authorization, where the patients came in having strokes, seizures, trauma, were rushed from the ER to the operating room for an aortic dissection or a heart attack. And there's, no way any rational person is going to say, slow down, I need to get their wallet so we can register this patient before we do anything. And certainly if the patient is septic, comatose, encephalopathic, there's nobody around to give you demographic information. There's really nothing that you can do as a hospital's institution, or you should be expected to do, or legally required to do, to guess who you're providing care to. The hospital is under obligations under UMTALA, federal regulation, to provide care and stabilize the patient without regard to their ability to pay. And we look for these extenuating circumstances and set them forth in the appeal. Supporting this, in regardless of what we're going to talk about today, at the root of all of these things is the idea of medical necessity. If you're dealing with a technical denial, you still have to be able to demonstrate that the care that was provided throughout the stay was medically necessary. So a brief narrative of what brought the patient to the hospital, but focusing once that establishment of medical necessity has been made on the extenuating circumstances that led to the inability to get an authorization becomes the focus of these. So if you think back recently to the Change Healthcare breach that happened earlier this year, where a lot of payer portals were down, there's a great example of things that are well out of a hospital's control that may lead to some confusion down the road and lack of payment because the insurers forgot that they were offline during these dates. If you want to move on to the next slide, we'll get into some of these. So this is an example of an overturned denial. As I said, you can deal with these in a written fashion. My personal experience as a physician advisor has been, if I can demonstrate a really good, solid reason as to why the hospital was unable to seek care, and this does not come back overturned, I will not stop at that point. The next call is going to be to the medical director at the insurance company to have a discussion to make sure they understand what is being said. But in this particular case, you can see what the denial letter said, and it basically relates to lack of timely notification. They say this is an administrative decision, and since the hospital was probably in network, there's going to be a statement that you can't turn around and balance bill the patient for these denied services. Next slide. So this is in essence what you're going to pull out of the patient accounting notes. You want to start with a summary of the denial as Karla's put forward here. So summarize the denial language to frame what you're going to talk about. You're going to answer the question or the allegation that they put forward. And then you're going to provide a substantiation of the medical necessity. You see this all the time, and it's really strange. I don't know how it happens, but it does happen. The patient presents with an expired insurance card or a lapsed insurance card, but the dates on it are ambiguous, still appear to be valid. They may have forgotten to make a payment on that plan or something. And the hospital will act on the basis of the information they were given. They're not psychic. They don't know that the patient's employer may have changed insurers in the meantime or something else. They actually call the insurer. The insurer gives them an authorization number. So presumably the insurer is not checking to see if patient's active in their system. And then it may be down the road, it may be after the patient's discharge, that the family comes back, they start getting bills and they say, oh, you billed the wrong insurance, here's the right insurance card. In this case, the hospital staff contacted the payer and asked for a retroactive authorization. And then they denied this, saying that you failed to notify us generally within 24 hours, 48 hours of the patient's admission. Go on to the next slide. So we wrote a typical medical necessity appeal. Sorry to move this around. Discussing the need for hospitalization. Then we showed that the hospital acted in a reasonable manner to ascertain the patient's insurance coverage. They're not psychic, they're not clairvoyant. They couldn't know that payer B was lurking behind the scenes, especially given that payer A or payer 1 didn't say to call payer B, that this wasn't our patient. They actually got an auth number. And this is part and parcel of, as I said, what you want to demonstrate with one of these technical denials is we tried our best. Use your common sense here. There's no way in heck that we were going to, under these set of circumstances, have been able to call you. We acted as quickly as possible once we became aware of the facts, and accordingly, we should be paid for the services that were provided. I will say with technical denials and really all of the denials that we're talking about today, in addition to the medical necessity component, there generally are legal arguments that can be made once you do prove the medical necessity of the case. We're not going to talk about the idea of legal arguments that exist under state law, under contract law, and under various federal regulations. There'll be separate webinars coming up where we do incorporate that and give you some ideas of how to tie these two together. We're going to focus on more the medical and technical components today. So in this case, you want to go to the next slide? With the demonstration of the medically necessary care, the demonstration of the facts, ultimately this was overturned. I'll give you a quick story, a similar story involving a patient with a $180,000 bill that was rushed in, had a hemorrhagic stroke, seizing, intubated, no family, no identification. Wasn't until 2 months later, after the patient had died and the estate was settling, that someone bought in an insurance card and tried to contact the insurer. They denied. Similar to this, appealed, it came back, denied again, and it resulted in a conversation with the medical director saying, listen, this was a John Doe essentially until the family showed up and the information became available 2 months down the road. But it took that call to get that overturned. So if you are writing these and you're seeing them come back and you have a very good, valid reason and they're still coming back upheld, reach out to your physician advisors, reach out to your managed care departments and have them escalate these to the managed care, their counterparts on the managed care side. So Karla, I'm going to turn over case study 2 to you.
Okay. All right, this one is the only case study that has not been overturned. The reason is this is a brand new, there's a brand new appeal writer, Patty, I think you're out there, and we were working on this just about a week and a half ago. It came in, and I thought, this is a perfect example for our webinar. So we do expect it's going to be overturned, but it's a really good example of a technical denial. It was administratively denied because the H&P said it was a planned inpatient admission. Okay, so what happened when we read through the PANs, the patient accounting notes, and just another note about the patient accounting notes. When I first started writing appeals, I had no idea those things existed. So that's why we're talking a lot. One reason we're talking a lot about the PANs. They are of vital importance. So if you don't know what they are, find out. Talk to somebody in New York.
Strongly suggest that you do talk with your administration, your supervisor, risk management, and do not incorporate these notes or disclose them to the insurer. They're often protected under peer review or other legal statutes, and the hospitals will have varying policies on disclosing these to outside sources. So while you may be able to glean information from them, you got to be careful disclosing this work product to the insurer. And as a department, I would urge each of you to seek clarity from your respective organizations on the policies of incorporating these notes into, or providing the actual notes themselves to the insurer. Sorry,
Exactly.
little risk comment. So.
Yep. That's exactly right. So in this particular case, they got the denial, and they called the attending physician's office, who happened to be a cardiologist, and their office staff was confused because they said, well, they never did prior authorizations for direct admissions. So that's when it started to think, okay, this was not maybe a planned admission like the H&P said. Maybe this was a direct admission. Just started to look a little more into the chart. And in the H&P, it actually said it was a planned admission for milrinone initiation. Next slide, Tammy. So what we brought out in the appeal is information that was on the face sheet. And Dr. Smith talked a little bit about the face sheet a couple minutes ago too, about the important information that you can get from that. And this is something else than when I was a busy nurse on the floor doing bedside nursing, I didn't pay a whole lot of attention to that face sheet. I didn't have a use for it. I didn't have a need for it. But whenever you're writing appeals, it can give you a lot of really good information for you to use. So in this case, the admit time, the inpatient admit date and time. The admission type, it was urgent. It doesn't say anything about it being planned. It was an urgent admission. The point of origin, it was a physician or clinic referral, and specifically it was a cardiology referral. So this person came urgently from the cardiologist's office and have the referring provider's name. So we know from that, yeah, it doesn't look like it was a planned admission. Next slide, Tammy. So then when we looked further into the chart, we only saw one entry that said the patient was a direct admit, but there were multiple times that directly admitted for milrinone initiation was documented throughout the medical record. So that is the type of information that we put into the appeal. It said exactly where it was. The face sheets are generally part of the medical record. So what we like to do, we like to highlight that information, and we say the page number. So to make it easy for the reviewer, you don't want to make things more difficult for the reviewer. Make it easy for them to find exactly what you're talking about. The patient was sick, decompensated heart failure, needed to have this milrinone. So that is not usually something that is planned, at least in my experience. Reason for admission, acute decompensated heart failure, and then directly admitted in all these different pages. So the reviewer is able to go to page 30, see highlighted directly admitted, can go to 78, 88, all those pages and see directly admitted. So we're hoping, and we think that this will probably get overturned. Everybody makes mistakes. There's different language programs out there. Maybe it didn't type it up correctly. I mean, who knows? But there is a plethora of information that it was not a planned admission. So that's the kind of information you want to get.
One word of caution with face sheets is they are updated often throughout the stay as different information in the becomes available over the course of the stay. You may even be looking at a face sheet that was updated after discharge. So pay close attention to the last updated date on the face sheet box to make sure that the information that's on that sheet accurately reflects what was known while the patient was in the emergency room or in the first 2-3 days of the hospitalization. quite often where a insurance becomes available mid-stay or after the fact, an updated registration is done, and that will give you the misleading appearance that the insurance, the correct insurance was available at the time the patient came into the hospital, which in fact would not be true. So little attention to detail with some of the timing on those things is critical.
Okay. Tammy, next slide, please. We're going to talk a little bit now about a couple patient status studies. Next slide, please. Dr. Smith?
Yeah, so I think there's still, with the changes in Medicare Advantage, and they weren't necessarily changes, but they were clarifications as to how MA plans should be behaving effective January 1st. It was a level set from CMS, which was really served as a reminder to say the patient was going to be an inpatient under traditional Medicare coverage. The patient should be considered to be an inpatient under a Medicare Advantage plan. In this case, we have an elderly lady presents to the ER, really an extremist. She's very dyspneic. If you look at her vitals, she's objectively, the wheels are coming off the bus. She's tachypnic, hypoxic, signs of heart failure and or pneumonia. And aggressive therapy started in the emergency room and during the stay. So those of you that use intercall, we talk about intensity of service and severity of illness. Both of those concepts are here. She's on IV antibiotics, IV Lasix, respiratory support as well. One of the key things in the 2 midnight rule is, and I'll remind folks because I often forget as I'm looking at charts, is the timing of the 2 midnight rule starts with the initial provision of care in the emergency room. It doesn't, that clock does not start running when the decision to admit is made. And this is significant because a patient presents at 9 p.m. on a Sunday and the decision to put them in observation or make them an inpatient happens at 1 a.m. on Monday, 4 hours later. They've actually crossed 1 midnight at that point. So keep a scratch pad or keep in your mind as you're looking through these charts how the counter for the 2 midnight rule actually works. In this case, the patient was documented to have failed a period of observation in the emergency department, was admitted to telemetry, and I think most hospitals at this point have fairly boilerplate language, smart phrases to accurately capture the necessary documentation of an expectancy of a stay greater than at least 2 midnights. Multiple acute diagnoses were made. Very intensive therapy was provided. And on the basis of this, this case was ultimately overturned. You want to run on to the next slide? Authorization was requested but denied. The thing that stuck out on, to me, and I don't know whether this was a deficiency in the chart or whether this was a procedural deficiency on behalf of the payer, was there was no rationale available. It was unclear whether the rationale was not available or it was not made. They just simply said no, or did they say no with a reason? Level of care was reviewed, was written, and I think Karla will get into this in much more detail, but it's very important when you're putting things together, medical necessity, length of stay cases, that you're able to point to fact and not opinion. And we'll take a look at that in a little bit later here, I think in this letter or the next letter. But you want to really be able to buttress or support the need for inpatient care through evidence-based guidelines. One of the things that I'm a big proponent of is actually using Medicare's own actuarial data, the predicted length of stay, the geometric mean or average length of stay LOS or GMLOS for the particular DRG, as to prove that there was an expectation of a long hospital stay. So if you look up the expected length of stay for a patient with sepsis, you may find that it's 5 or 7 days. And that's, if the patient's being admitted with sepsis and there's a 2 midnight rule signed at that point, you can often point back to CMS's own actuarial data to support it. Beyond that, evidence-based guidelines invaluable in supporting these types of arguments as we move on to the next slide. Published medical literature, and you got to be careful here. I actually was interesting last night. I was using a Gen AI program because we were always looking at, the use of AI and its emergence in denial community and how insurance companies are using this, et cetera. And it actually generated for me what seemed to be a fairly convincing medical citation, literature citation, and I was flummoxed to actually go back into Google Scholar, scholar.google.com, which is a great place to look for peer-reviewed journal articles, and find out that the journal article actually didn't exist. The program actually made it up. So, very, very good lesson about using AI and folks that might be dabbling in it in this field is that it is really user beware. But stick to peer-reviewed medical journals. Primarily, we're looking in North America, Canada, the US, European journals as well, or national or international guidelines. New England Journal of Medicine, Journal of American Medical Association, Journal of American College of Cardiology, in support of anything that you find. And then when you do find an article, you want to make sure that your patient actually fits the demographics that article was talking about. You may have, in this case, 85-year-old woman, you may find an article on respiratory failure saying it could be managed safely in an outpatient setting. And that, as you start to look at the demographics, you may find that study related to healthy adults under the age of 50 with no comorbidities. So certainly something you might see the insurance company use to argue that inpatient care wasn't necessary, but not something you'd obviously want to cite in support of your argument. As we move over to the next slide. So in summary of what was going on here, this is the patient status, the medical literature. Will, as a matter of routine, highlight the portions of that medical literature that relate to the particularities of the case at hand. Karla, I'm going to put you on the spot here. As relates to copyright laws and republishing literature and summaries of things, because is that something you can talk to just as a word of caution about how much of a journal article you can repost, or just as a rule of thumb?
It's not a whole lot. Yeah,
Okay.
you do need to be very, very careful about that. I would suggest that you talk to your compliance department or your legal department if you have one, just to be sure that you aren't going over or outside of the bounds of that. Yeah, good point,
Yeah.
Dr. Smith.
It is. You got to be careful. You can't pull the whole thing. And as Karla had said, work with your institution to get some guidelines from legal or compliance or risk, because at some point you're going to start to, these articles are generally copyrighted by the journals in which they're published, and you don't want to violate copyright law. But you do have a right to repurpose this and summarize it as relates. The style and the way we cite these slides are available for download, but this is a standard way to cite articles. And in terms of our letters, we always put these after the clinical argument. So as you're putting the overturn or appeal sandwich together. This tends to go at the bottom portion after the clinical summary and narrative has happened. You want to make your case based on objective data, but before the summary. So you want to move over to the next slide. And then you want to tie things together. So, say that my patient actually met the criteria as discussed in this article. Summarize what the article's recommendations were, and then tie it back into the case at hand. And it's a very concise way to serve this information back up to the appeals department at the insurance company. Ultimately, my goal and belief in citing evidence-based guidelines is the insurer may not reverse their position, but ultimately, if you're aggressive in pursuing these and you take them to arbitration, mediation, independent review, you have given that reviewer a roadmap to agreeing with you. And that's ultimately why we're putting things here. If we're getting to an ALJ, an administrative law judge, you've given them a roadmap to really find no reason not to agree with your position. You've shown that the care was reasonable. It's supported by medical standards, reasonable medical practice, and as such, you should be paid appropriately for it. It may be that the insurance company disagrees with you, and we'll talk in different webinars down the road about escalating beyond that, but invaluable to build your best case initially, and this is part of doing that.
And if I could just say real quick, the only reason you see part of that reference down here highlighted in yellow, it was just for convenience. We don't put it like that in the appeal. It was just what's that?
I said I will boldface things so that So
yeah.
I will bold so if there's a number of criteria that are listed to describe a syndrome or a symptom, I'll boldface the portions that the patient had to make it obvious that this is how the patient fit into this.
Yep, absolutely. Okay, are we ready for the next slide? Okay.
Okay, so we will cite in these letters, typically with Medicare Advantage, we want to remind them of their obligations under CMS's rules and regs. And so we incorporate rules, regulations, CMS's guidance into our Medicare Advantage appeals. These slides are available for download. You'd be able to copy and paste these into your Medicare Advantage templates if you're using them. But these basically summarize what we said, which is if traditional Medicare was going to cover the care as an inpatient, then Medicare Advantage plans are obligated to the same standard. And then ultimately, and this gets a little vague sometimes in how it can be interpreted legally or procedurally, but if they gave you a prior auth, and we're just going to limit this to the inpatient discussion today, there's a whole separate debate on whether this language applies to clinical validation. But if you get a prior auth and they say inpatient is appropriate, they can't come back after the fact once a bill is paid and revoke that prior auth and say, we've looked at the case now and we've changed our mind. The only reason they could do that is if they were misled, that they had been given incorrect information or, quote, fraudulently induced to give you an inpatient authorization, which certainly is never the intent, I think, of any hospital. So that's this small thing for any reason except for good cause. So if the insurer could show that the hospital had a pattern of misleading them about the severity of illness or what was going on with the patient, then they could reopen it and revoke it. But otherwise, there's an expectation that once the authorization is granted, that it's inviolate. It can't be subsequently redetermined and taken back. So let's move on to the next slide. Karla, I think this is your ballywhack.
Yeah. So, okay, so now we're gonna start delving into DRG validation, which is coding validation, and clinical validation, which is a separate process from coding. So just very briefly, because our purpose is not to really go into the different types in depth, but this is per CMS when they were instructing their auditors. DRG validation is a process of reviewing physician documentation, determine whether the correct codes and sequencing were applied to the billing of the claim. Should be performed by a certified coder. So these are, it's coding. It's coding based on coding guidelines. And then they go on to say clinical validation is not that. It's a separate process that involves a clinical review of the case. In other words, for the DRG validation or coding validation, they're saying, coder, you did not code the case correctly. For clinical validation, they're essentially saying, doctor, you did not diagnose your patient correctly. So it's two separate things. Okay, Tammy, can you forward? All right, you've seen this before earlier today too. First and foremost, never ever believe the payer's rationale is correct. And this is true for any case, but particularly I think for the coding and the clinical validation or the CV denials, because they give a ton of reasons to deny and you have to look at every single reason. I'm going to show you some ways how you can push back. Okay, next slide. All right, we're going to take a look at a couple coding cases. Next slide. All right, this is one that was overturned. The payer was saying that a wedge resection that was done was only a diagnostic procedure with no therapeutic benefit. Therefore, the qualifier that was billed was not the correct one. Well, the professional coder who looked at this chart had a different opinion, and part of it was based on a coding clinic, coding guidelines. And then she went on and she explained the provided rationale is incorrect because. And then she went on very clearly and rationally and truthfully why they were wrong. The documentation supports a therapeutic component and Z is therefore the correct qualifier. The qualifier X is exclusively used for diagnostic procedures only. And then in the preceding paragraph, as you can see, she explained what those differences were. So this is one way that you would handle a coding case. Can we go on to the next one, please? So also in our coding denials, what we include the very pertinent information. We want the reviewer to be able to go right straight to the information that our appeal writer used and find exactly what they're talking about. So we like this format, document source and date, go to the operative note, got the date, the pertinent information. You're not putting everything in, only what is pertinent. And the page numbers where that very pertinent information can be found. There again, if you want to make it easy for that reviewer. Next slide, please. And then it go on to explain some of the coding rationale. In this case, it's this particular chart graph that explains how that particular procedure was coded and why it was coded correctly. Next slide. And then we have a part where it's similar, very similar to the evidence-based guidelines or the reference sections in our clinical validation and also in our medical necessity cases, where they list the source, whether it's a coding clinic. In this case, it was a couple of coding clinics that were pertinent. Make sure that it was that it was effective at the time the patient was in the hospital. So you don't want to get burned by putting something in there that your patient was in the hospital in June of 2024 and the coding clinic didn't come out until the next month. So you want to be very cognizant of that, not just with the coding references, but the clinical references as well. So that those are the things that we used for this particular case, and it was indeed overturned. Okay, next slide, please. So another coding case. The reviewer alleged that malignant neoplasm of the left kidney was an incidental finding. It didn't require any workup or management while the patient was in the hospital, therefore it should not have been reported. So that goes back to the reportable criteria for a diagnosis that the coders need to follow. So that's exactly what the appeal writer based the appeal on. The payer's rationale is incorrect because, in accordance with, and I'm not going to read it all out to you, but it explains, I think, very nicely why that particular diagnosis should have been coded. It would have been an incorrect coding decision to not code it because it met the definition of a secondary diagnosis. There was a urology consult. There was evaluation by the patient's providers and treatment. There was a renal ultrasound. So all those things qualify as making that diagnosis reportable. Next slide, please. And this is how we like to put it in our appeal templates. There again, the document source and date and the pertinent information. If it's not pertinent, it really shouldn't be there. So we will obtain a renal ultrasound. It was an incidental finding on the CT scan, but that does not mean that it was just an incidental thing. They worked it up. It was worrisome for renal cell carcinoma. Recommend a non-urgent outpatient urology evaluation, but they did have, let's see, how did they do that? They had a renal ultrasound done. So it does meet the reportable criteria. You only have to have one. You don't have to have all of them. One is enough. Next slide, please. And here we reiterate the same information. And this time we take it right out of the coding guidance for reporting purposes. The definition for other diagnoses is interpreted by one of these conditions: clinical evaluation. The hospitalist evaluated the condition, they formed a plan, met, a renal ultrasound was done, and so it met. And I believe this case was also an uncertain diagnosis. It was. And in the discharge summary, it said they were concerned. It was concerning for cancer. So it was in the discharge summary or the final documentation at the time of discharge. So coders are instructed to code it as if it existed or was established. That's exactly what they did. They followed all the rules. So the case wasn't overturned. So next slide, please. Okay, clinical validation. We're going to try to go through a little quickly here. We'd like to be able to take a couple questions. So, okay. Oh, this is a sepsis one. I thought you'd string. Thought you guys might string us up if we didn't have a sepsis one that got overturned.
The end of sepsis September, so we'll acknowledge this. And I think, in the interest of catching up on this, I'll say that there is no consensus in the medical community as to sepsis 2, sepsis 3. It's all over the place. If you look at CMS and the core bundles, how they're measuring hospital performance, they use sepsis 2. The insurers have seized on the idea of sepsis 3, and some of them even gone further and created their own, quote, modified SEP 3 criteria to under their contract. They're giving themselves the right to define sepsis. So at the end of the day, work with what you've got in the chart. Create an argument as best as you can. If sepsis is documented, look for the supporting clinical facts around it. If you can derive a SOFA score, even if it wasn't put in the chart, take the opportunity to do that.
Absolutely.
And then focus on sepsis 2 criteria and how that was validated. At the end of the day, a lot of these things are going to end up getting into contractual arguments because, as I said, a number of payers are changing their provider manuals to say that we will define sepsis any way that we decide, and they're really coming out with some creative definitions that are even more restrictive than SEP 3. So do your best, pull in objective information wherever possible, showing that the patient was sick, that they were being treated for that illness, and ideally show that it, persisted. The documentation wasn't a one-off. We'll admit to rule out sepsis, for example. So you want to demonstrate the presence of an infection, the intent to treat the infection. A reminder: blood cultures positive in patients with sepsis less than 50% of the time. Negative blood cultures do not preclude the diagnosis of sepsis clinically. You're fortunate if you get them, and half the time they come back to misleading anyhow. Next page. We talked about looking for objective information. The lab's a great source of things. You're looking for lactic acidosis. Anion gaps, which you can calculate, can suggest a lactic acidosis if it was not present, if it was not actually measured or calculated. Look at CO2 levels to show metabolic acidosis. Things like tachycardia, tachypnea, oxygen levels, temperatures, all of those things go into, you're telling a story here. You want to tell a really dramatic and compelling story with as many facts in it, which in this day and age is probably something I shouldn't comment on, but be factual in it. And the facts will speak for themselves, and they'll tell the tale that you need to tell. Next slide. Okay, so the prior slide just got into the argument. You want to go back one?
Yeah. Just go back one. There we go.
Yeah, this summarizes
this is
essentially what I was saying.
Yeah.
Go ahead, Karla.
Yeah, just wanted to give you guys some examples here of some possible arguments. In this particular case, it was really clear. The hospital used sepsis 2, the providers were using sepsis 2, and there were quality reminders in there. And that is really the I don't know if that's what made the difference or not. I don't know. This case was overturned, but we did make a point of showing that the hospital and the physicians, it was very clear they were on the same page. They were endorsing sepsis 2. The physicians said why they felt it was sepsis 2, so tachycardia and leukocytosis, I believe. The bottom line is this case was overturned.
I will add that if you go back to the 2016 coding clinic that says the insurers kind of tend to put their thumb over the first portion of that coding clinic, but it says that hospitals and insurers are basically free to define, have clinical definitions of certain conditions. We often see letters that say the insurers are free to define that, and they come up with the definition. There is nothing in that coding clinic that says if a hospital has says we're going to endorse sepsis 2 as our standard, that is any less valid than the insurer's definition of saying we're only going to pay you for sepsis 3. And that's where these arguments under contract law start to come into play, and what does your contract say about these types of disagreements. So if your hospital or your state recognizes sepsis 2, make sure you point to that. That's invaluable. It then becomes a contractual issue down the road as these things move forward.
And if I could just add, if your state is one that recognizes sepsis 2, like New York is one of those states, there are several others, send that information along with your appeal. This is what your state says sepsis is, and we do, yeah, it can hurt. Okay, next slide. We're a little over here already.
Yeah, we'll speed up here. Plenty of evidence-based guidelines. I know the AHDAM website, we've done a number of webinars on sepsis before, so if you want to access the website and look at those, we did a series last year on Sepsis September with a bunch of guest speakers from around the US talking about this very issue. If you want to educate yourself on that, I would take a look at the AHDAM website. But as I said, you can find evidence-based guidelines to support whatever position you want to take on this. Next slide. This is similar. I can make this really quick, which is quite often we see insurers when they create a denial, maybe misunderstanding or misinterpreting something like a radiology study and using that to support their position. We'll often see this where get a denial for pneumonia and there's no infiltrate on the x-ray. It's a single view x-ray. Infiltrates can lurk on those type of x-rays behind the heart. The patient may be dehydrated, may not have fluffed out and infiltrate at that point. Similar case here, infant that was born with transient tachypnea of the newborn and was put on CPAP. The hospital and the neonatologist taking care of the newborn felt this was a respiratory distress syndrome. They got into the idea and fixated on the abnormalities in the chest x-ray. And what was pointed out here was that the patient was on CPAP, which is significant because there's a long course of requiring respiratory support here, but that the use of CPAP as well, the positive pressure in CPAP can cause hyperinflation on the chest x-ray, which is what was sort of driving this dispute back and forward. So having some understanding of the limits of things like radiology studies. We see this a lot with cerebral edema after strokes, where there's discussion of edema. In situations where the study may not be exactly what the insurer is claiming it's saying, may disagree with the clinical issue at hand. So you want to move over to the next slide? Yep. As we said earlier, you lay these things out in a very organized fashion, and you want to pick apart piece by piece the auditor's rationale. Basically, if they make multiple points, break the argument down into as many responses. I think the key things here, Karla has outlined in different colors, which each of these is a unique response to the points that were made in the denial. Talked about the idea of hyperinflation in the chest x-ray, pointing out that the auditor failed to take into account the baby was on CPAP, which is going to distort the x-ray, and then other allegations or claims that were made, and then how we were able to systematically pick them apart using facts in the chart. Ideally, you want to make sure you reference the progress note pages where you're finding that information so you can serve that back up to them. And then we'll move on to the next page. You want to go into the references? Was this references from the prior letter, or was this references in general for the talk, Karla? This was for the talk.
These are just references in general. We are about 5 minutes past the hour, so I'm sorry we're not going to have time for questions. But if you wrote questions in, we will do our best to get them answered within the next couple weeks, and we will we'll have them posted on the AHDAM website along with a copy of the webinar, a recording of the webinar. Now, the recording is not eligible for CEs and CEs, of course. So next slide, Tammy. So yeah, we can't do questions and answers, so I'm sorry. Next slide.
We do questions. I'll do answers. You do questions, email them in, we'll get them answered.
Yeah. Oh yeah. Yeah. We absolutely will. We just can't do it verbally now.
Yeah, as an association that exists for your benefit and education, that's one thing that we will do. So what we tend to do is wait for all of the questions to come in so we can group them together into like questions, and then we'll provide those answers and groupings once we get them all sorted.
So we want to thank you all very much. We appreciate you being here. And if you want more information about anything about AHDAM, anything that was presented today, questions in general, you can always email info@ahdam.org and we will get back to you. All right, well, again, I want to thank you very much. And with that, we're going to conclude our webinar. Have a good rest of your day, everybody. Bye.